Welcome to the deep dive. Today we are taking on a really critical topic in maternal health. We're looking at how we screen for and diagnose diabetes during pregnancy. You probably know it as gestational diabetes or GVM, and you've given us some very dense material on the protocols, the physiology. So our mission here is to, cut through that complexity and really clarify the timeline for you.
And we should establish the stakes right away because this isn't some rare issue. It's a common challenge. Diabetes in pregnancy is actually one of the most frequent medical complications out there, and it leads to some very serious risks for both the mother and the baby. For the mother, you're talking about things like preeclampsia, a much higher chance of a C-section.
But the physiological link to the fetus is what really stands out to me. It's just so direct. When a mother's blood sugar is consistently high, that extra glucose, it just crosses the placenta. The fetus is basically getting overloaded with fuel.
That's a perfect way to put it. And the fetal pancreas sees this sugar surge and it just ramps up its own insulin production. We call that fetal hyperinsulinemia. And in this context, insulin acts like like a really powerful growth hormone. It just promotes fat storage.
And here's the problem. It's not uniform fat storage, is it? It's disproportionate. It accumulates heavily around the shoulders and the chest. This is what leads to a condition called macrosomia, which just means an excessively large baby. And that size difference dramatically increases the risk of a very dangerous complication during delivery called shoulder dystocia.
And the danger doesn't stop at delivery. I mean, the second that umbilical cord is cut, that constant supply of maternal glucose is gone instantly. But the baby's pancreas doesn't know that. It's been conditioned for months to overproduce insulin, so it keeps going. And the result is neonatal hypoglycemia, a sudden, dangerous drop in the newborn's blood sugar that requires immediate management right there in the delivery room.
Wow. It sounds like a tightrope walk that really continues for the first few days of life. So knowing that, we have to start the very first step, which is figuring out the different kinds of diabetes we're dealing with during a pregnancy.
Absolutely. The first critical distinction is between gestational diabetes mellitus, GDM, and what we call pregestational diabetes. GDM, by definition, is high blood sugar that develops for the very first time during the pregnancy.
Okay, but here's the challenge for clinicians, right? A lot of patients don't have screening before they get pregnant. So when they come in for prenatal care and their glucose is high, how do you know if it's new, if it's GDM, or if they actually had undiagnosed type 1 or type 2 diabetes before they even conceived?
And making that distinction, that differentiation at the start of prenatal care is absolutely vital. It's all about risk. Patients with pregestational diabetes are at a much, much higher risk for serious complications. We're talking congenital anomalies in the fetus, more severe maternal health problems. They need intense monitoring from day one.
I know historically the standards was just, if it was found during pregnancy, you called it GDM. But that's changed. We have better tools now.
We do. We can apply the standard non-pregnant diagnostic criteria very early on in the first or early second trimester. So for instance, if a patient has a really high measure of their average blood sugar over the last few months, that's the HbA1c of 6.5% or more, that confirms it. It's pregestational diabetes.
And just to clarify, the HbA1c for everyone, it's like a measure of commitment, right? It shows the average sugar stuck to your hemoglobin over a couple of months, so it's a longer view than just one test.
Exactly. Other big red flags for pregestational diabetes would be a fasting glucose of 126 or higher, or a 2-hour glucose of 200 or more after a 75-gram glucose test. Finding that early means we manage that patient with the intensity they need right from the get-go.
That makes complete sense. So once we ruled out pregestational diabetes, the focus shifts to screening for GDM later on. And the key decision here is all about timing.
And that's where defining high risk becomes so important. The protocol is clear. Every pregnant patient gets screened, but when you get screened depends entirely on your risk assessment.
So let's define that. What does that profile of metabolic vulnerability actually look like? It's more than just one thing.
It is. A patient is considered high risk if they have an elevated body mass index, a BMI of at least 25 or 23 for patients of Asian descent, plus one or more other very specific risk factors.
So the BMI on its own isn't the trigger for that very early screening. It has to be paired with something else that suggests, a breakdown in glucose control is likely. So what are those other factors?
Well, history is a huge one. GDM in a prior pregnancy or a history of delivering a very large baby. We define that as 4,000 grams or about 9 pounds. Also, having a first-degree relative, like a parent or a sibling, with diabetes.
And then beyond the family history, you have to look at the patient's current health.
Precisely. A personal history of PCOS, polycystic ovarian syndrome, or any cardiovascular disease, those are big markers. Hypertension found on their exam counts. And pre-pregnancy morbid obesity, a BMI over 40, that's another major risk.
What about their initial labs? Because I imagine you can see some warning signs there before they even develop full GDM.
Oh, yes. Even a slightly elevated HbA1c of 5.7% or higher is a warning. It's below that pregestational cutoff, but it's not normal. Same goes for their lipids. Specifically, low HDL, the good cholesterol below 35, combined with high triglycerides over 250, that profile points to a systemic metabolic stress that really ups their GDM risk.
Okay, so we've got our two pathways defined. The average risk patients and then the high risk patients with that vulnerable profile. That takes us right to the screening timeline.
For your average risk patient, it's pretty standard. The screening window is between 24 and 28 weeks of gestation. But the high-risk patient, they get screened much, much earlier, right at the beginning of their prenatal care.
So for that average risk patient in that 24 to 28 week window, we're talking about the classic two-step protocol, the 50-gram, 100-gram sequence.
Right. Step one is the 50-gram, 1-hour oral glucose tolerance test. The patient drinks a glucose solution, and we check their blood sugar exactly 1 hour later.
And this is where it gets a little ambiguous, which I find fascinating. The actual cutoff for what's a normal 1-hour test, it varies. Some places use 130 milli-GDL, others use 140.
And that tension just reveals how complex it is to set these benchmarks. There isn't enough definitive evidence to prove one is absolutely better than the other. So the guidelines just say pick one 130 or 140 and be consistent. It shows you that even in these critical screening steps, there's still a degree of clinical judgment involved.
That's a great point. So regardless of the threshold, if that 1-hour screen is high, the patient moves on to the big one.
Yeah.
100-gram, 3-hour OGTT.
Yes, and that one's much more intense. It requires a fasting blood draw, then drinking a 100-gram glucose load, and then having your blood drawn at 1, 2, and 3 hours after that.
Okay, let's switch to the high-risk patient. They get that early screening, first trimester usually. What if their early 1-hour test is normal? They're in the clear.
For a little while, yes. But they have to be retested again between 24 and 28 weeks. Pregnancy hormones can and do change things as the pregnancy progresses.
And if that early 1-hour test is elevated, they go on to an early 3-hour test.
They do. And here's the slightly counterintuitive part. If that early 3-hour test comes back normal, they still have to be retested at 24 to 28 weeks. But because they already failed a 1-hour screen once, we skip it the second time. They go straight to the 3-hour diagnostic test.
Wait, why skip the 1-hour test then? Wouldn't you just run the whole sequence again to be safe?
It's really about efficiency and reducing the burden on the patient. The likelihood of them failing the 1-hour screen again is so high that making them do it just delays getting to the definitive answer from the 3-hour test. You save a step.
That clarifies it. Okay, so let's say the patient has done the 3-hour test. Now we're looking at the numbers to see if it's GDM.
The diagnosis is confirmed if 2 or more of those 4 values from the 3-hour test are elevated. And our sources point to 2 different but acceptable sets of criteria for this.
Right, let's touch on those. There's the Carpenter and Costand criteria, which is what's most commonly used today. It's generally seen as the more stringent or tighter set of rules.
And then there's the older set, the National Diabetes Data Group, or NDDG criteria. It's a bit more lenient, meaning the glucose levels have to be higher at each point to get a GDM diagnosis. Carpenter and Costand really replaced it because it helps us identify patients at slightly lower glucose levels who still clearly benefit from treatment. It casts a wider, safer net.
Just for context, under those tighter Carpenter and Costand rules you're looking at, fasting below 95, 1 hour below 180, 2 hour below 155, and 3 hour below 140. 2 or more values at or above those numbers means a diagnosis.
And it's worth noting that a single-step 75-gram test does exist, but it's really not preferred. The 2-step approach makes sure we're only putting patients through that intensive 3-hour diagnostic test when it's truly necessary.
There's one really interesting scenario, though, that kind of sits on the fence: impaired glucose tolerance. This is when only one of the values on the 3-hour test is elevated.
Right. And while that's technically a normal result by the definition, you absolutely cannot ignore it. That single high value indicates impaired glucose tolerance, and these patients still have a much higher risk of adverse outcomes, especially having a large baby, that macrosomia we talked about.
So even if they don't get the official GDM diagnosis, they need to be watched more closely than someone whose test was completely normal. The numbers say normal, but the risk profile says be careful.
Precisely. It just shows that risk is a spectrum. It's not a simple yes or no.
So once GDM is confirmed, the clock starts on management, and that always starts with lifestyle.
Absolutely. The immediate goal is education. The patient needs comprehensive nutritional counseling, focusing on a carbohydrate-controlled diet, and instruction on safe, regular exercise that's appropriate for pregnancy.
And the success of all this really depends on daily self-monitoring. Patients have to check their own fingerstick glucose levels multiple times a day when they wake up, fasting, and then after meals.
And the targets are very strict. Fasting glucose needs to be consistently under 95 milligdl. For after meals, the goal is either a 1-hour reading below 140 or a 2-hour reading below 120. And we review those logs every week or two to see how they're doing.
And those targets are what lead to the official classification and the management plan.
If a patient can consistently hit those aggressive targets with just diet and exercise, they're classified as A1-GDM. The management is just to keep doing what works for the rest of the pregnancy.
But if they can't consistently hit those targets, if their numbers are all over the place, they move to A2-GDM, and that requires medication.
Yes. For A2-GDM, the first-line pharmacotherapy is typically insulin. It's effective, and it doesn't cross the placenta, which makes it very safe. Metformin is a reasonable second-line choice, maybe for patients who decline insulin, can't afford it, or have trouble with injections.
So that really covers the whole journey, from that critical first step of differentiating pregestational diabetes to defining the high-risk patient, breaking down the two-step screening, and finally setting those strict management goals.
We've really hit on how timing and precision are everything, especially with the risks of macrosomia and neonatal hypoglycemia. But I want to circle back to something you mentioned earlier, that clinical ambiguity.
The 130 versus 140 cutoff for that first 1-hour screen.
Exactly. We think of standardized protocols as the bedrock of medicine, right? But when the evidence base isn't perfect, as is the case there, institutions have to choose between two equally viable but different benchmarks.
And what's so fascinating about that is what it tells us about how medicine is always evolving. We rely on these hard numbers, but the fact that a crucial first step can vary by 10 milli-GDL because experts are still debating that perfect balance between catching everyone and not overtreating, it reminds you that medicine isn't about perfect certainty.
It's about the ongoing research-driven effort to refine those benchmarks. It challenges this idea that all protocols are rigid laws. They're not. They're just the best scientific consensus we have at the moment, and they're always subject to change with new evidence.
That's a really powerful takeaway.
Yeah.
Thank you for walking us through all this. We hope this deep dive helps you navigate these complex, high-stakes conversations with a bit more confidence.